Morning, friends. Welcome to Pediatric classes. Today, I will discuss about important topic that is immunotherapy. We had a state IAP Kerala allergy chapter conference hosted by IAP Malana a few days back. So today, I thought I'll discuss about the topic which is entrusted upon me during the conference. That topic is immunotherapy. So with this intro, I am going to share my screen now. So if you have not subscribed to my channel, kindly do subscribe and support this initiative. Immunotherapy, as you know, it's a very upcoming thing. It has been there for a long time, but as the prevalence of allergy is increasing, it has been found that use of immunotherapy is going to do wonders for not only for children but also for adults. So in this session, we'll discuss about the definition, mechanism of action, indications, types, advantages, etc. So what is AIT or allergen immunotherapy? It is a recognized key therapeutic modality for the treatment of allergic diseases. It is a method of desensitization or hyposensitization. What happens there? There is administration of increasing amounts of specific allergens to which the patient is sensitized. So suppose a patient has allergy to pollens or dust mite, you are giving actually small quantities in an incremental way to train the patient's immune system. So what happens there? There is a gradual exposure of increasing amounts of allergens. Then he develops immune tolerance, which helps to tolerate the allergen. So thereby reducing the allergic response. And it also, immunotherapy helps in disease modification, which causes symptomatic relief. It prevents the development of new allergies and also inhibits the progression of disease. So this is the mechanism of action. As you can see from the first part, so we have an allergen exposure here. So what happens? So the allergen is taken up by the dendritic cell, taken to the Th0 cells, which actually forms lots of Th2 cells, which goes and stimulates the B cells, and gets converted to plasma cell, go for isotype switching, and lots of IgE is produced, which go and bind to the mast cells. Then on subsequent sensitizing the patient. So on subsequent exposure, what happens? There is fastly this allergen go and bind to the IgE, which is actually sitting on the mast cells. So this will cause coupling reaction and the release of lots of mediators causing the allergic response. Whereas in immunotherapy, we are giving small controlled amount of allergens, which actually cause stimulation or upregulation of T regulatory cells. So T regulatory cells are actually CD4 plus CD24 plus cells. Actually, they secretes or helps the formation of IL-10, IgF beta, which actually helps in the formation of IgG4. IgG4 is a blocking antibody to IgE. So, and also it also lots of IgA. All these things will compete with IgE for the allergen binding sites and thereby reducing the immune response. And also it causes the shift of this Th2 pathway, that are allergic pathway, to a Th1 pathway, and produce lots of interferon gamma also. So in short, there is an upregulation of CD4 cells, that is CD4 plus CD25 plus cells. There is production of protective IgG4 antibody. There is increased Th1 cytokine production, there is interferon gamma, and there is an induction of state of immune tolerance to the offending antigens. Thus, AIT changes from an allergic milieu to a non-allergic milieu, that is from a Th2 to a Th1 response. So when can I consider immunotherapy? So when we need to consider, we generally don't jump and just start immunotherapy on the first day. My teachers always used to say that never ever discuss only about immunotherapy, start a patient on immunotherapy on the first visit. Actually, there are other modalities that go for take a detailed history, go for the concerned testings, and then start on pharmacotherapy. If there's an inadequate symptom control despite pharmacotherapy and avoidance measures, or if there's a desire to reduce the morbidity from allergic rhinitis or asthma, or reduce the risk of anaphylaxis for the further future insectines, we can consider for immunotherapy. Or when the patient experiences undesirable adverse effects from pharmacotherapy, or when the avoidance is not possible at all, or when the disease is progressive. These are the conditions when we should think of immunotherapy. And when do I say the disease is progressive? Disease is progressive when there is an increase in the frequency of symptoms, or there's an increase in the annual medication requirement, if there's a reduced response to medications, or there's an increase in severity of symptoms, or they're taking more time for the symptoms or attacks to respond. Or when you say that the patient is having the progression of symptoms, like for example, allergic rhinitis patient, they're going on to asthma and or vice versa. So these are the definite indications for allergen immunotherapy. Allergic rhinitis or allergic rhinoconjunctivitis with sensitization to seasonal allergies like pollen, grass weeds, or perennial allergies like dust mites, molds, pet danders, etc., or insect venom allergies like bee or wasp stings. Allergic asthma once controlled and also can be considered in patients with atopic dermatitis with sensitization to house dust mites. There are certain absolute contraindications for immunotherapy, like, for example, uncontrolled asthma. Because what happens when the asthma is not under control, as you know, for immunotherapy is also associated with systemic reactions and anaphylaxis, everything. So once the asthma is not controlled, there's more chance of bronchoconstriction, more chance of fatalities following immunotherapy. So asthma needs to be under control. Always check your PFR before the initiation of or even every shots of immunotherapy. And pregnancy is another absolute contraindication. If the patient is already started on immunotherapy, he or she can continue it, but you do not initiate an immunotherapy during pregnancy. Then, children less than 2 years, malignant neoplasm, AIDS are all absolute contraindications for immunotherapy. Coming to the relative contraindications, beta blockers. Why so? Because suppose we give immunotherapy, the patient has some anaphylaxis, the drug of choice is adrenaline. And you are going to give adrenaline, and if the patient is on beta blockers, it may actually, the effect of adrenaline may be negated because or reduced by the use of this. So that is why beta blockers is a relative contraindication. Cardiovascular disease, children 2 to 5 years, immunodeficiencies or use of immunosuppressants, autoimmune infections, all these are relative contraindications. So when does it go beautifully? When there is a proper patient selection, then the young patient with a mild disease is the most ideal patient for immunotherapy. And we need to have a proper antigen selection. How can I select my relevant or proper antigens? That is by a proper history. When you get relevant examinations and also concerned testings. So when you take the history, you ask the patient whether the patient is having symptoms throughout the year, or whether means it is a not a seasonal one, it's a perennial one. You ask whether the patient is having symptoms more indoor or more outdoor or both. This indoor, probably it is an indoor allergens, we have to give more importance, or outdoor we have to give for other allergens. So we have to give the proper antigen selection, and proper composition has to be done, and proper administration. So proper antigen selection. So what happens here is, sorry. So as you can see, so this is an allergic skin prick test which we have done in our hospital for a child. So here, this patient is sensitized to dust mites and also pollens. So whereas when you see this case, this patient is sensitized only to house dust mites. So when I select the antigens for immunotherapy, I should be careful to select what all. In the first case, I should need to have a combination of both HPM and pollens, whereas the other one, I need to have only pollens. And proper composition and proper administration also need to be done. So when I say proper administration, what are the types of AIT? It can be administered as subcutaneous immunotherapy, or sublingual immunotherapy as drops or tablets, or novel AITs like oral immunotherapy, intralymphatic immunotherapy are all underway. Mostly in India, we follow actually SCIT and SLIT. In SCIT means what we do is we give the allergens as subcutaneous injections. This treatment has got a build-up phase and also a maintenance phase. Build-up phase is when you actually give small doses of allergens till you reach a maintenance dose. So that takes time. So you can either rush schedule, it will take around 3 to 7 days. Or like there, what happens is we are giving the injections daily, multiple injections, and reaching the maintenance dose faster. But risk of anaphylaxis is more with rush therapy. In cluster, we can give 2 or 3 injections in a day, but not consequent days. Consecutive days. So what happens when you give on a Monday, you can call the patient on a Wednesday or a Thursday for the second shots. And likewise, you build up to the maintenance dose, it will take around 4 to 9 weeks. And in a conventional therapy, we actually start very slow. We give 1 injection or max 2 injections in a week. So like then you build up and reaches the dose. So that particular day when you start conventional dose, in a day, suppose Monday you are giving 1 dose, second day you will give Thursday another dose. So only 2 doses. So whereas in a cluster, in Monday itself, we will give 3 doses with a gap of 1 hour. So cluster is different, convention is different, rush is different. And once you reach the maintenance dose, we need to maintain it. And that is for every month, we have to take an injection for around 3 to 5 years. SLIT, sublingual immunotherapy, is tablets for Dasmite that are currently approved that in India. Then it's also available ragweed, certain grasses, etc., but not available in India. Compared to SLIT drops, these are liquid allergens placed under the tongue and held for some time. So these are not DCGA approved, but widely used off-label. Reactions, SCIT and SLIT both have reactions. SCIT has local, systemic, and anaphylaxis risk. So always make sure that SCIT is taken in a medical setting. Make sure the asthma is very well controlled before the initiation of therapy. Whereas SLIT has also has for local and systemic, but mostly it's local, with itching of mouth, swelling of buccal mucosa, abdominal pain, rarely hives, etc. Now, there are multiple studies comparing the efficacy of sublingual versus subcutaneous immunotherapy. It has been found that SLIT is definitely safer, but it is more efficacious. Further into the details, when you see, it has been found that SLIT is comparatively more efficacious for pollen than SCIT, and SCIT is comparatively more efficacious for asthma than SLIT. So multiple studies are going on. Now also it has been done. So it's all going on. So coming to the duration, again, multiple studies have been done. And in the one of studies, it is found that we need to give at least of 3 years, minimum 3 years. Then only we will have a disease modification and a long-term tolerance. So please note that effects of immunotherapy will take around 6 months to come. Okay. So we have to tell that also to the patients very clearly, because they should not expect that we start immunotherapy today and they'll get the response another 1 month or so. We should tell it will take around 6 months for it to act. And the beneficial effects of immunotherapy persist even after immunotherapy is discontinued. So what are the advantages of AIT? They have a disease-modifying effect. It prevents the development of new allergen sensitizations, and also it prevents the onset or progression of asthma in patients suffering from allergic rhinitis or allergic conjunctivitis. So let me ask you one question. This is a good candidate for AIT, 18-year-old male, both AR and asthma. There's history of disease progression. He's highly sensitive to inhalants, that HDM and grasses, and his PFT is normal. And there's a good correlation, like he's having perennial symptoms, and he also has more indoor symptoms and occasionally outdoor symptoms also. So there's a good correlation. So he is a good candidate. Whereas in an bigger adults, 60-year adult smoker, see asthma with COPD, the few positives to HDN and cockroach, there is significant obstruction and poor correlation. He is not a good candidate for AIT. Now, coming to the third scenario, this patient which we had seen around 6 months back. This is Master X, 11-year-old child, complains of severe itching of the eyes and nose, watering of the eyes, not able to attend his classes, was not able to even open his eyes properly when he had come to OPD. There's no history of recurrent cough, food allergy, or skin allergies. Mother is allergic to asthma. Child is sensitive to HDM. So these are the allergic skin test for him. So first we advised avoidance measures for him and started him on pharmacotherapy, that is both nasal spray and the eye drops. So this is always a team effort. Always when this, you can see in this picture, there's giant papillae in the conjunctiva. So here we also took the consultation from the ophthalmologist, and we actually started the patient on first of all, eye drops with both steroids and histamine eye drops. So olopatadine and fluorapatide was started, and later shifted down, and also nasal spray with antihistamines plus steroids. Nasal spray was started. He was very well controlled with avoidance and pharmacotherapy, but once the eye drops are, we were trying to taper up the eye drops, and once a few days he misses, he just tends to have more symptoms. And that is the point time when we actually discuss about immunotherapy to the patients. And we had multiple sessions on the advantages and other things, and we discussed. And if this is baby is a good candidate for AIT because allergic conjunctivitis is there, rhinitis is there, and we can actually prevent the progression to asthma. And what antigen should I be using for him? We should be using dermatophagoids, terronitis, and farinate. And the route of administration, we can go for either SCIT or SLIT, but SCIT is preferred and it is approved. And the duration of therapy is around for 3 to 5 years. And from this, we can see that there was a initiation after few months, what happens is there was actually slight reduction. The papillae size have actually come down, but the height of the papillae, the size is to come down. And with proper continuation of the immunotherapy, we hope and pray that all the eye symptoms settles down, and the patient has a much greater relief, and it will prevent the progression of the disease. So in short, the take-home messages are the proper administration of correct antigen in a properly selected patients is important for AIT, and the duration is around for 3 to 5 years. And please note, this is the only therapeutic modality which can change the course of the disease. So when you see a patient with allergic rhinitis or conjunctivitis or asthma, consider, think in the back of mind whether this patient will be benefited by immunotherapy. Then don't hesitate to advise and let the patient read about the immunotherapy. Let us advise to them these treatment modalities are available. So with this, I want to thank the IAP Kerala President Dr. Rehna sir, Secretary Dr. Gobiman sir, IAP Allergy Chapter Chairperson Dr. Jijo, Secretary Dr. Nimmi, our Malanar President Dr. Suni Thomas, Secretary and Organization Malanar President Dr. Hassan, and Secretary Dr. Reni, and the Organizing Chairperson or Alargapon, that is Dr. Suni Thomas, and Secretary Dr. Jasmine, and all the people for giving me that opportunity to deliver this talk during the allergy conference, which was held a few days back in Todupuzha. Okay, thank you so much, and hope you like the session. And if you like the session, don't forget to like it, comment, and share it. Thank you.